your risk factors. It addresses what we can do to identify ovarian cancer at an early stage. It also identifies certain things that are within our control to actually change the course of this disease. So if you look at ovarian cancer in general, it's actually not a very common cancer. So if you live to be 70, the risk of ovarian cancer is actually just anywhere from 1.3 to 1.4%. So it's not a very common malignancy. But what we do know is that when people get ovarian cancer, it's not diagnosed early. And so that basically is, the crux of the matter, which is why we have such a poor mortality. Among all the women who develop ovarian cancer, I would say about, based on which study you read, anywhere between 15 to 18% of all ovarian cancers tend to be driven by mutations in certain mutations which are called germline mutations, which means that these are mutations which are inherited through your parents or through the lineage of your family. And why is that important? It's important because if we can identify patients who actually have that mutation, we can, number one, develop a surveillance strategy. So we actually watch them closer. We may be able to identify these cancers earlier. And more importantly, in those women, once they reach a certain age, we can actually provide them with risk reduction strategies so that they actually don't develop this cancer, right? So when we look at all patients with ovarian cancer, all women with ovarian cancer, I said in the general population, the risk is about 1.3%. Now, if you have a family history of ovarian cancer, risk of developing ovarian cancer with a first degree or second degree relative actually goes up from 1.3% to anywhere from 5 to 7%. So it's not a huge increase, but it does make a big difference. And finally, patients who have a mutation in one of the two genes, BRCA1 or BRCA2, that risk, obviously increases to 20 to 40%. But why is it that we tell everyone with ovarian cancer to have genetic testing? It's because in a lot of the studies that they've done, they found that 44% of women who actually have a BRCA mutation have no family history. So what happens is that if you just go by family history, you're going to miss all those women who don't have a strong family history. And so you will miss being able to provide them with certain testing, certain drugs. And that's one of the reasons why we recommend, and those are the guidelines which are published by NCCN, by SGO, and all the major cancer networks.
Perfect. For the folks that are listening in, our friends, do you have any questions for Dr. Kamat as it pertains to genetic testing for ovarian cancer survivors, as well as, mutation carriers or not? Please ask away. This is your forum. Rachel, I see you.
I know I'm sorry I look like this, but this is the way it is. I'm going to turn myself off after I ask my question.
I just got it, so it's okay.
Hi, Dr. Kamat. Thank you so much for your time and for doing this. Appreciate it. I have two questions for you. The first one, it does relate to genetic mutations and stuff. So it's actually a question with respect to my daughter because I carry the BRCA1 mutation. And I know typically they suggest that screening should start at the age of 25. And I assume that means whether or not she's actually had the genetic test for the gene and potentially CA125 or something. But what I'm wondering is when she turns, should she see a gynecologist sooner? And should it be a regular gynecologist? Or what do you suggest for, 18 to 25-year-olds who may carry this genetic mutation but may not have been tested for it yet? Who should they see and when should they see them?
So that's actually a good question. So, one of the reasons why we don't recommend that girls get tested too soon is because whether you like it or not, knowing that you have a mutation does have some sort of an impact. It doesn't have to be a negative impact, but it has some sort of impact psychologically, let's talk about your daughter, right? So, I mean, when we know that there's no intervention we are going to be doing specifically for the fact whether she's BRCA positive or negative, there's really no need for her to get tested that early. So usually we recommend starting the testing at 25. In a very few percent of patients, if there's someone who was diagnosed with ovarian cancer at, say, 33, then we usually would recommend that her daughter or their children get tested 10 years from the time of the earliest. So there is a little bit of a discrepancy, but in yours, if it's beyond 25, then we recommend doing the testing at 25. Now, as far as your daughter, anybody who's concerned, I mean, I usually recommend that everyone, once girls get to be 18, I think it's very important for them to get hooked up with a gynecologist. Not so much so that they have to have a pap smear, because a lot of them may not be sexually active. So if they're not sexually active, they don't really need a pap smear right away. But I think it's very important for them to meet with a gynecologist, number one, if they are sexually active, to get on their pap smears done, to have a breast exam done, to kind of understand, make sure their periods are regular. It's basically like getting hooked up with a primary care physician. So I think it is very important, even if she sees, once she has her testing at 25, say for example, she is positive, and she does have surveillance with a GYN oncologist, I still recommend that she has a gynecologist that she gets familiar with, can trust, because it's not always easy to get into a GYN oncologist. And when you come to see us, we are sort of focused on, basically looking at surveillance. And it may, if your periods are painful, that may not be, may not be just exactly what we're, that may not be the focus of what we're trying to address.
I'll also add here just one thing, Aparna. I know that you mentioned the pap smear and the the mammogram as well. These are great things to keep in mind, and also the fact the vaccination, the HPV vaccination, Rachel. That is something that it's in our hands to take care of our children, honestly, and that's a vaccination that I think boys and girls both should have. I have two boys and I have taken them to take their vaccinations exactly when they were due. So, things that we can do, we should do, is the way I look at it. So if that addresses your question, Rachel, I think you had one more, right? Before we move on.
I do, but it's really specific. So you move on and I'll ask it later.
Okay. So anyone else here, if you have any questions on genetic testing, I see a hand. And please go ahead. It's your forum.
Hi, my name's Lucy, and I'm curious as to the ethnic breakdown in terms of genetic inheritance for ovarian cancer. Could you speak to that?
Yeah. With as far as if you look at the ethnic in general, it's kind of interesting to know worldwide, the incidence of BRCA1 and 2 mutations is between 1 to 300 to 500 people. Okay, so it's actually, that's usually the average incidence across all races, all regions. But obviously, we know that Ashkenazi Jewish ancestry, or women are people who are born, and it kind of started in Eastern Europe. In some of those communities or some of those sects, the incidence of BRCA1 and 2 mutations can be as high as 50%. So just being Ashkenazi Jewish, without even any family history or any risk factors, that itself is a red flag, and that person should get tested. So that's one of the biggest risk factors, irrespective of any other risk factor. But otherwise, beyond that, there are certain groups which have, there's a small group in the Southeast Asia, but it's not something which is, these are just little clusters of families, but in general, all across the world, the incidence is about 1 to 3 to 500.
I guess what I'm wondering, when I've gone to the lunches in the past, which we get back to wonderful lunches.
Yes.
There were African-American women there, and I was kind of surprised that African-Americans get the BRCA1, BRCA2 gene. And not just that, there could be other genetic influences.
No, so just with BRCA1 and BRCA2, like I said, the rate is 1 to 300 to 500, irrespective of race or, you know, any ethnicity. So it's not that, you know, it's basically the incidence of BRCA1 and 2, other than a few certain areas, is not much higher among Blacks versus, you know, white people or women. So among Ashkenazi Jewish, that's the only very well documented group or, you know, group of women where the founder mutations are so prevalent that it's the incidence is as high as 50%.
Mm-hmm. I'm asking the question because I used to do presentations on cancer prevention, and yes. I would say overall, most African Americans do not think they're at risk with that genetic mutation.
I think a lot of it also has to do with, you know, who gets tested. You know, so it may be that women, African American women, don't get. They were not offered testing as much, or they didn't get testing as much. But you know, I have several patients who are, you know, African American who are positive, and so I don't think that there's that much of a difference in, you know, the incidence of BRCA1 or 2 mutations just based on race. I think it's more based on where the founder mutations originated, and so it's more like region and cluster of families as compared to just race by itself.
Thank you.
Thank you, Dr. Kamat. Moving on, I had a question on diagnosis, but we have all our survivors here that have already been diagnosed. So I'm going to park it for this question and maybe perhaps ask this to you later as we go to the final few minutes. So just moving on to my next question, it was about treatment. So obviously we have seen a lot of advancements in this field, right? Ovarian cancer in the last 5 years in terms of treatment. There's this PARP explosion, if you will, so many other therapies on the horizon. However, we do see that, at least, you know, the majority of us think that most of these therapies are mostly meant for the carriers, right? The mutation carriers and the PARP at least. But we do know that there was this new zejula, I think, indication that came out in summer of this year, which says that it could be used as maintenance therapy for all patients, ovarian cancer patients, irrespective of their mutation status. So talk to us a little bit about the advancements in this field in the, you know, since let's say the last 5 years or so. How is the field evolving, and where do you see the exciting therapies going, which are now on the horizon as well for the BRCA as well as the non-BRCA patients?
Yeah, so I mean, you're right. You know, and for the, you know, since I was doing fellowship, I mean, over the last even 33 decades, we didn't do much. There wasn't much of a, you know, huge change in the landscape of, you know, how we treat ovarian cancer. Most of it was, you know, most women would get Taxol carboplatin. When they progressed, they would just go to second line and third line chemotherapy. It was actually the first big advance was when Avastin actually came into the, you know, the forefront in the treatment of ovarian cancer, where we started looking at ovarian cancer not just as treating the tumor, but treating the tumor microenvironment. And so with Avastin, we looked at treating the tumor, the blood supply to the tumor, and then that's where the first thought of maintenance therapy came into being, where we felt that, you know, women, especially those who are at high risk for recurrence, like most of the women with stage 3 or 4 disease, we know that most of them, about 80% of them, it's, you know, in spite of having stage 3 or 4 disease, will undergo remission. But we also know that within 12 to 18 months, there's a very high chance that this cancer is going to come back. So the goal was to try to find some treatment that would actually be effective to kind of avoid putting them back on chemotherapy soon. So that's where maintenance therapy came into being. Then when we found about BRCA mutations and the prevalence of these mutations, and when the PARP inhibitors first came into the forefront, we then had this exciting therapy which we could target for patients who had a germline mutation for BRCA1 or 2. But as the field evolved, what we found was that the PARP inhibitors are not effective only against those patients who have a germline mutation of BRCA1 or 2. They are also effective with patients who have a somatic, which means a mutation in the tumor, but they may not carry it in all their cells. So those tumors are very, very sensitive to these PARP inhibitors. And then there's something called homologous recombination deficiency, which means that these tumors by themselves have some defect in being able to repair their DNA, which makes them very sensitive to these PARP inhibitors. So that actually increased the number of patients who actually would be helped with this mutation from the 15% that we talked about, 15 to 18% who have germline mutations, to now we're talking about patients, almost 50% of ovarian cancer, because between somatic mutations, between hormone HRD tumors, as well as germline mutation, that almost comes up to close to half of all the ovarian cancers we deal with. So this is something that is available to a lot of the patients who we now treat. And so in all the trials that have been done with maintenance therapies with PARPs, especially the NOVA trial that just came out, and what it shows is that in patients who have, and the PRIMA trial obviously, which both these trials looked at zejula or niraparib as a maintenance therapy, either at the first line or after the first recurrence in all comers, irrespective of their mutation status. And what they found was that even though the most robust benefit was seen in those who actually carried a germline mutation, there was a significant benefit in those who actually had this other sort of gray zone, which is the somatic mutation or HRD. And even among the wild type, so wild type means that they absolutely have no mutation, anything. We don't know what caused this cancer. And even in those patients, there was about a 3 to 4 month increase in the progression-free survival. And at the end of the day, I think if we look at the 3 to 4 was just the median, there were a lot of them who were more than that. So if you could get those patients to more than 6 months without any chemotherapy, then potentially these patients are still deemed to be sensitive to platinum agents. And I don't know how, I think I need to make this, that's a pretty big deal, because once you're sensitive to platinum, then you are actually able to get treatment with carboplatin, which is one of the most effective agents we have for ovarian cancer again. So there has been a huge, kind of a benefit, or there's been a huge advance, I think, in the way we think of ovarian cancer and the way we treat it. So with niraparib, there are also other PARP inhibitors that has actually opened up many, many more options for patients.
Thank you, Dr. Kamat. I know that Cynthia had a question here. Cynthia, would you want us to read your question, or would you like to ask Dr. Kamat directly? It's your forum. We would love to hear from you. Cynthia, are you here? Okay, so she had while she probably gets her off mute, I'll ask her question anyways. So she basically is saying that she just completed her first round of carboplatin. She has clear cell stage 3A ovarian cancer, and she's waiting to receive results from her follow-up CT scan. So genetic testing is pending, but usually clear cell is not BRCA positive. the impression I get is there is little available for the maintenance for clear cell histology, and are there any new developments in the treatment of clear cell in more advanced stages?
That's that's
Is that
great.
Cynthia? There she is. Cynthia is right here.
Yes,
I'm
yes.
glad you're doing well from chemo. Are you done with all six cycles, or?
Yes, I am. Thank you. Yes, and I am waiting on the results of the CT scan. I don't have that yet to determine how effective that was, but I'm hopeful. So yeah.
So, I mean, I think clear cell has always been a little bit of a challenge to treat because, number one, it's not that common, right? So we don't have as much, experience with it. I think even now, we still bundle clear cell with the rest of the with the serous ovarian cancers in all the clinical trials. Clear cell probably behaves a little bit closer to serous as compared to a mucinous tumor, for example, which now we treat more with like a colon cancer regimen. Now, with a stage 3, you still, I don't know if you got Avastin with your chemotherapy.
No, I didn't. No.
As far as maintenance, one of the questions that she asked me, in patients who have stage 3 or 4, one option would be to treat with Avastin, to give with the chemo and then do Avastin maintenance. I think that the PARPs are in the zejula, the niraparib, it would be something that you would be eligible for, even with a clear cell. And so the trial that was done included all cell types. It did not include mucinous, but it including clear cell. Obviously, the percentage of clear cell was much smaller because it's just not that common. But yes, I mean, you would still be eligible if your oncologist felt that you were at really high risk. You still would be eligible. And one of the hallmarks of sort of response to maintenance therapy with the PARP is responsiveness to platinum. So we know that tumors which are responsive to carboplatin tend to, sort of have some response to a PARP inhibitor. So that is something that you might want to talk to your, treating physician. But other than that, outside of clinical trial, I mean, I don't know of any specific clinical trial that is targeting clear cell specifically. Not that, that I'm aware of. But I think you still would be eligible for a PARP, as maintenance. I would not add Avastin at this point because, since you did not get it along with your chemotherapy, the benefit that was shown was only in the group of patients who actually got it with their chemo and then went on to maintenance. And I would, in your situation specifically, I would probably reserve the Avastin, God forbid, if you need it, later on.
Right. Okay. Thanks very much.
You're welcome.
Cynthia, did you have another question that you wanted to ask? In the chat, we see that you had a couple, or are you good?
Nope, that was it. Thank you.
Okay, perfect. I know that Rachel has another question before we move on to our next topic. So, Dr. Kamat, Rachel is asking that if you progress on PARP, can you try another one, or is it one and done since they work similarly?
That's a very good question. Obviously, hasn't been studied only because PARPs have not been on the market that long for to get to the point where you go from one to the other. But off-label, I mean, yes, they are all, they work along the same pathway, but all of them have different efficacies and they all have different, pharmacokinetics. So I know of people who have gone from one to the other. If it's not usually FDA approved to do that, but it's only, I think, a question of time before someone does a study where they, where we I'm sure where we look at, follow-up PARPs, like if you progress on one, can we go to another? Or, for example, if you start on one but cannot tolerate it for whatever reason, for something which is a very specific side effect to that particular PARP, can you switch to another one? I think that those questions still need to be answered, but I have a feeling that we probably will see people doing that more and more.
Thank you, Dr. Kamat. We have more questions coming in. I know that Tammy had a couple questions. Tammy, you want to come on screen and ask?
Good afternoon. It's so good to be here. I want to say thank you to the Overcome Foundation. You especially.
You mean to say Overcome family, right?
Yes, yes. It has been such a wonderful resource for me. I have a couple of questions. I don't want to take up a lot of time. One of my questions is on the PARP. I was diagnosed with stage 3C high grade January 14th of 2019, and I completed, I actually had intraperitoneal chemotherapy.
Okay.
I was able to complete the entire regimen. My question is, since then, the zejula has become available for non-BRCA, which I am.
Mm-hmm.
And I did ask my gynecological oncologist at my last appointment about the possibility of starting that now. My treatment ended July 1st of 2019, and I'm in that watch and wait period. And I'm just trying to, I'm very proactive. So I'm thinking about that recurrence and living in that fear. Why do you need to start that immediately when you finish frontline treatment? Why can't you start that at any point, or do you just save that in your arsenal in the event you do recur?
So, that is like a key question, because what has happened is a lot of patients like you who finish treatment when maybe the prima, because you would be approved for receiving PARP maintenance based on the trials, which were the prima trials, which were actually the results of which were published later last year. So it was not FDA approved then. So the only reason you weren't put on a PARP was because it wasn't approved at that time. So the question is, the reason we say that it should be started right after, you finish within about 8 to 12 weeks is mainly because that's how the trial was designed. So, that's how the FDA approval was done. To say, the goal of, so in your situations particularly, I would probably, the fact that you have gone, what is it now, July? So over a year, you would know to the day. So yes, so if, God forbid, if you were to get a recurrence, then I think that, most of us would say that hold off on keep the PARP so that you can, get the chemo again with the platinum. And now we know that when you have a recurrence, honestly, if it's a very small volume recurrence, you may not even need to do all 6 treatments, because the PARPs have been shown to be as effective whether you have a complete response or a partial response. So usually what I would say is that, in your particular situation, I would probably hold off on doing any treatments, because even though it seems like you're just taking a pill, I mean, they do have side effects, right? So we have to monitor your blood counts, especially zejula can cause your platelets to drop. It causes fatigue. I mean, these are not completely, they're not just like sugar pills. I mean, they do have some side effects. They do affect your bone marrow. And so down the road, if you needed chemotherapy, then that also could have some bearing. So, I mean, just for that particular question, I would say I would hold off, wait and see. And if you were to recur, then use it as a maintenance therapy, because it would definitely add benefit. But in the bigger question that you asked, you know, why can't I just do it now? It's mainly because that's how the trial was set up. I think that as we get more and more familiar with this, as we get more and more, I think a lot of people may start doing it if they start seeing more and more of the benefit. But right now, the FDA, the approval was mainly because in the trials, the maintenance was started about 12 weeks after completion of chemotherapy.
Okay. I do have another question, but it might be more beneficial to ask it later or more relevant later in the next segment.
Okay.
Thank you.
Thank you. Thank you, Dr. Kamat. I think we have a couple of questions from Irina. Irina, would you like to? I'm hoping I'm pronouncing your name correctly. Would you like to talk to Dr. Kamat directly, or would you like us to read your question?
Helps to be unmuted. So one is a quick question because you mentioned pap smears.
Yes.
I recently, had this debate about whether to have pap smears or not. I've been diagnosed in 2016 and I didn't have a pap smear since. And I asked the doctor at one time and they said something changed with guidelines, but but to me is pap smears determine cervical cancer, not the ovarian. What are the guidelines?
Yeah, sure. So in your situation, you said you were diagnosed in 2016 with ovarian cancer, correct? Mm-hmm. So you had a full hysterectomy, correct?
Yeah. Yes.
If you've had a complete hysterectomy and if your cervix did not have any precancerous cells, then the guidelines are, irrespective of whether you have ovarian cancer, if you've had a hysterectomy, you don't need to get a pap smear as long as you did not have any precancerous cells on the cervix, or you didn't have any abnormal pap smears in the past. So as far as you're concerned, you would not need a pap smear. Obviously, I'm sure you're getting pelvic exams routinely.
Yes. Yes. And I asked this question, I don't question, I have two doctors and they're the best. I don't question the doctors. It's just that I'm on the forum where was ovarian cancer survivors, and that was a debate. And trying not to give advice for something I don't understand. So thank you. I have another question that relates more to Tammy's question on PARPs. So when time comes to, when doctors thinks that it's time to prescribe PARPs, there are 3 approved, and I hear that they're all the same. You mentioned that efficacy may be different, and I'm talking about HRD proficient and no other gene mutations. So what is the algorithm in doctor's mind to pick one versus another?
You guys are right on target, because this is such a question that I get asked all the time. So it actually, I wouldn't say that one is more effective than the other, because if you look at, their efficacy is not that much different. But if you look specifically their indications, right, or when you can use them, they are different. So for HRD proficient, for example, tumors which are BRCA wild type, in the sense they don't have a germline mutation, no somatic mutation, and they're not HRD deficient. So the wild type, the only PARP which is approved, right, for frontline treatment is right now is zejula. Olaparib is or Lynparza, along with Avastin, has been approved in the frontline for patients who are either BRCA mutation, a somatic mutation of the tumor with BRCA, or if they're HRD deficient. So for wild type, right now, zejula is the only one which is approved. So that's what I would, use as a frontline maintenance, after the initial chemotherapy. Now, for patients who have recurrent disease, right, if they have platinum recurrent disease, then you have 3 different options. You have zejula, you have Lynparza, or Rubraca. So all 3 of them have been approved in that situation. So in that situation, I would basically go with a few things. So if patients have had chemotherapy in the past and they have had a lot of difficulty with, for example, anemia, then anemia is one of the biggest problems that we deal with Lynparza or with olaparib. So in that situation, then I might consider doing some other PARP. There are certain patients who may have a lot of difficulty with for example, thrombocytopenia where the platelets go down. Then in those patients, if we are going to do niraparib or zejula, then there are some criteria. So we usually don't start those patients on a full dose. We actually modify their dose and kind of decrease their dose to 200 milligrams to start the treatment. So there are many, and then the last thing is, honestly, your physician's familiarity with these drugs. So a lot of us will, kind of prescribe what we're a little bit more comfortable with, especially if the efficacy for all three is, in the same ballpark. I hope, I don't know if I've answered your question.
I think you did, and I appreciate such a good question, a good answer.
Thank you.
Thank you.
Okay, so moving on are there any other questions on PARP or any other questions that you have in mind? We have about 20 minutes. Otherwise, we had a couple of questions for Dr. Kamat. We can go ahead and ask. Again, it's your forum, you drive the questions. So if you have any questions that you want to ask, please ask away.
I do have one other question, and this is just confusing information that I have been on some forums as well. And so I have a question about your initial CA-125 when it's drawn, and I've talked to some people that on the forums that said theirs were 20,000, theirs were 7,000, and there really, that doesn't have any type of, I guess, meaning, for lack of a better word, or significance, that the difference in that number. Can you talk just a little bit about that to kind of give me some clarity on that?
Sure. So, CA-125 is an antigen or a protein that is actually secreted by the cells that line the inside of the abdomen or the peritoneum. It also lines the surface of the ovary, and it lines the lining of the fallopian tube. So it is. It also is secreted by the same cells which line the the inside of the pleura or the lining of the lungs. So as a result of that, the CA-125 can be elevated to different degrees in different types of tumors. For example, a clear cell carcinoma may not secrete as much CA-125 as a serous carcinoma. A mucinous carcinoma does not secrete CA-125 at all at some times. If you have a cancer which involves a lot of ascites, where you're building up a lot of fluid in your belly, or you have a lot of fluid built up around your lungs, then the CA-125 can be reactive and can be very high. So there have been a lot of studies to try to see if the CA-125 by itself, the number can tell you, give you any kind of information. One of the things that it can tell you is the amount of disease. So it would be very unusual to have a very high CA-125 and have very minimal disease. So patients who have a CA-125 which is elevated, those patients are more likely to require what we call neoadjuvant chemotherapy, where we actually give them chemotherapy first to shrink the cancer down and not do surgery up front. So those are the things that, those are some of the ways that we use CA-125. Now, the biggest, for ovarian cancer itself, the biggest, I would say, the benefit of using CA-125 is mainly to see the trend. To me, whether you start at 200 or whatever you start out, the trend of the decline of the CA-125 to the treatments that you give have a huge impact to the overall prognosis and outcomes. So we know that patients who got neoadjuvant or got chemotherapy first, who have a sharp decline in their CA-125, whether it's from 20,000 down to 1,000 or from 1,000 down to 200, just a slope of decline does make show that those cancers tend to be more sensitive to carboplatin, the active agent that is given for treatment. So those are the kinds of things that we use CA-125 for, but you should not use it as an absolute. I think that it's more important to use it as a relative marker for yourself and your cancer to see how it is responding to treatment.
Is there any prognostic value to that number? I mean, or is it just tied to that decline or that slope?
So there's no prognostic. So they've looked at it to see patients who had very high CA-125s. Did that have an impact? Not by itself, but if that is an impact to the stage of their disease or the amount of volume of disease that they had, then it may have some prognostic importance. But of all these markers, the biggest marker that we have shown consistently to be prognostic indicators is number one, stage, but number two, the amount of disease that was left at the end of your surgery. And that is one of the reasons why we use CA-125 to help us guide, just figure out who should actually get surgery up front versus who should get chemotherapy, how many cycles of chemotherapy you should get before attempting surgery, because we do know that those patients at the time of surgery who have what we call an R0 resection have a much, much better outcome as compared to those who have a resection where there's tumors still left behind.
Thank you.
Thank you, Dr. Kamat. Tammy, did we answer your questions? We have time for a few more if you have any.
I want to allow everyone else to ask their question.
Okay, great. Does anyone has any questions for Dr. Kamat? If not, then we are going to move to a topic which is very dear to all our hearts, which is survivorship. So I know that Zori, you had a question for Dr. Kamat on survivorship you want to ask? Zori?
Let me myself first. Actually, yes. So survivorship is a huge step, but can also be the most ancient stage, of ovarian cancer journey. And we know that. What would your message be to our overcomers in staying vigilant and reporting symptoms? Also, please suggest ways that might address treatments, side effects, some of those that you see most often.
Sure. So as we get, better with our treatments for ovarian cancer, we're seeing more and more women actually, becoming survivors even with stage 3 and 4 disease. In fact, there's depending on which papers you read, anywhere from 30 to 40% of women will live 5 years or longer, considered to be survivors. So, in that survivorship, when you get to that point, the things that I always tell people, number one, the most important thing, obviously, is to be kind of vigilant about your own cancer, about the ovarian cancer that you had, to make sure that you, you stay on top of your surveillance visits to make sure that you don't develop a recurrence. But more importantly, whatever made you get that cancer to begin with, that means there's some sort of genetic susceptibility or some sort of environmental exposure, whatever you may call it, that might make you at a higher risk of getting a new cancer. So it's extremely important not just to be focused, on seeing your gynecologic oncologist, but also making sure that you keep up on the screenings that you have to do for other cancers. So you may be completely, you may be doing well from the ovarian cancer standpoint, but you still need to get a pap smear. You still need to get a mammogram. You still need to get a colonoscopy. So those are the things that, you need to make sure that you are doing the active surveillance you can to prevent or to screen for other cancers. So those are some of the things that you need to do for your general health. But I also tell people, I think that if you are lucky enough to be one of the survivors to be 5 years out, then I think you also have, it's very important that you actually look after the rest, your health. You've undergone surgery, you've undergone chemotherapy, there's been a big impact to your immune system. So it's very important to make sure that you follow up on the general guidelines for things that you need to do. So make sure your lipids are okay, make sure you have a cardiac panel done once a year, a diet, exercise, your bone density. So these are things that need to be done to kind of ensure that you can actually enjoy a good, healthy, active lifestyle, and you can enjoy being a survivor. So those are things that you need to do either way. One of the things that I see and I completely empathize with is that, even however long you've been without, have been NED or, have been in remission, anytime it comes to the point of seeing your oncologist, getting that CA-125, getting those scans, I know it is something that really causes a lot of anxiety. I tell patients, unfortunately, and I try to put myself in those shoes, and I feel like it's impossible to completely take that anxiety away. I think it's normal to have some level of stress. The way I look at it is that it's okay to have stress about certain things as long as it's kept in perspective. So if you're doing all the things that you can do, that you've done everything you can in your power to be as vigilant as you can. So then I think that it's completely normal to have some stress at the time of those tests. But, those are things that we all have to deal with, and having a good support system, being able to talk about it with your family, your friends, maybe even your physician, I think that goes a long way. I don't know if I rambled on a little bit. I don't know if I answered all your questions.
No, that was a great answer, Dr. Kamat. And I think you touched on a very important point about keeping things in perspective, even though, I, as a daughter, when my mom went through all those, return visits and the scans and everything, I can still remember the anxiety that we felt as a family as she went in for all those tests. So it's like you said, it's impossible to take it away completely, but there are ways to kind of address it and try to make it better as you go into, and there are side effects of cancer as ovarian cancer, which is whole another topic altogether. Maybe we can address in one of our next events, but that is also a huge part of survivorship, right? So the side effects that
Yes.
the overcomers feel, and those are real, that gets in the way of everyday life. And so those, to me, I feel like those need to be addressed more, with more attention and focus every day. So
I just wanted to add one more thing. So, I think you're talking about the testing and the anxiety and things like that, right? So one of the things I do tell people, though, is that just having to try to avoid the anxiety, or to try to avoid, there's some people who then get it so kind of engulfs them so much that they don't go see their oncologist, they don't do the testing. So that's the worst thing we can do, right? So that's one thing you should not let. If you stay on top of things, even if you were to find something, there's a very high chance that it's something that can be taken care of, and you can still live many years of productive life. So don't ever let your anxiety for finding out what's wrong prevent you from doing the testing that you need to do, because unless we know, we can't fix it.
That's wonderful. Thank you so much for saying that. That's a powerful statement right there. So for those listening, do you have any questions on survivorship for Dr. Kamat? Anything? It's your forum. Okay, so there are no questions on survivorship. I know, Zori, you had one, and we have literally like 5 minutes before we drop off. So maybe we can ask Dr. Kamat about her final message. Zori?
Okay, so the final, I mean, and I know you touched on this a little bit with the previous question, but your general message, if I can just recap, basically, don't let your anxiety get of you and allowing you to be open-minded about getting and finding out what is actually wrong. I know for me, anxiety is a big deal. So trying to get tested is always something I struggle with, but definitely thank you for your message. I really, really appreciate that. And I know that the survivors do as well. And at this point, that's the only question. What would your one message to our survivor community as they go through treatment for ovarian cancer? I mean, that was my takeaway from your previous statement, but I know if there's a personal message that you would like to share, that would be great.
Well, I mean, I think as far as ovarian cancer itself, I think one of the things, in the bigger community, even among the doctors and the physicians and, just general community, it's just raising awareness. So if we can talk more, we can do more of this where, we can share with people what the signs and symptoms are, increase awareness. The more we talk about it, the more women are going to know when to go to see their doctors when something comes up. So we're going to find it earlier. If we find it earlier, we're going to be able to treat it better. If we treat it better, more women are going to live longer. And in general, we'll make a huge impact in this disease. So, Ransi, what you've been doing with Overcome, I think has been incredible. I'm really proud to be part of this effort. But I think what you don't realize is that these small little, these 1 hour sessions that we do, if we can share this with people, there'll be 5 other people who may think about doing genetic testing, might think about, family history, and then find that they have something. And then that one person, that family could get a risk reduction surgery that saves their lives. So I think my big, message would be just talk more, educate yourself more, not just about ovarian cancer, but just generally about your health. Because at the end of the day, in my opinion, no one cares more about you than yourself, not your doctor. I mean, not that they don't care, but at the end of the day, if you're not your own advocate, you have to be your own advocate in all aspects of life, but more so in your own health. So
that's true.
Thank you so very much, Dr. Kamat. That was, again, yet another very powerful statement. And, those that joined us today, as you know, you've been to our, events before this as well. And you know that we did those big webinars and all that, our conference, our survivorship event that we did this year. But this particular forum that Dr. Kamat suggested, I think it brings the people in a more interactive and intimate setting, if you will, to ask the doctor and be in a conversational mode. I hope that you all enjoyed it very much, and we definitely would love to. Hi, Eva. I would love to thank all of you for joining us. Eva, did you have any question, or are you good with the information?
No, my questions was all about the anxieties. I just don't know how to deal with them, but I'm getting there. And the answer is good.
One thing that helps me is I take a friend. It helps.
What?
Take a friend with you.
Oh, okay.
And Eva, we will get to, I know that this topic is of great interest to all our survivors, and we will definitely host another session. Like Dr. Kamat said, I mean, this is a topic in itself, right? We need to address it in more detail, and so we'll get to that. But I hope this was meaningful for all of you. And Dr. Kamat, thank you so very much for your time. And we are so grateful for you to just come here today and give us 1 hour of your time and so much of your information. And all of you that are watching, I hope that you enjoyed it. This was different in the sense that we got to see you versus the webinar forum when we don't get to see you. This was more like we are all sitting together and chatting. So this definitely worked. And this was Dr. Kamat's idea. So all credit goes to her. So
Thank you.
Next time we'll do it over tea. How about that?
That sounds great. Thank you so very much. And if you don't have any more questions, we'll drop off for today. And Zori, did you have anything?
I just wanted to, again, thank everyone for joining us today, and also give us any feedback of, what we could do better, things that you would like to see in a more intimate forum like this. We welcome your feedback, as always. And thank you, Dr. Kamat, for allowing this, taking an hour of your time and joining us today.
Thank you so much. It was great being there. Bye-bye.
Thank you all.
So just email us and let us know what you think about today, anything you want in particular. And thank you very much.
Okay,
Enjoy the
goodbye.
Bye.
Bye.
Thank you. Bye-bye.